The presentation today is called the Allen Cognitive Disabilities Model, Intervention in Dementia Part 2. We had Part 1 last week. This is a theoretical and evidence-based understanding of history, development, and use of the cognitive disabilities model in dementia care. And again, like last session, it's being recorded. I'll make this brief because she's got a lot to go through, but Patricia Cornell, OTD, has over 30 years of clinical experience as an occupational therapist and is a passionate expert in understanding the connection of the brain and everyday behavior. She's the founder and clinical director of VitaCura Services, and I'll put that link in the chat in just a moment. She's also the president of the Global Action Coalition for Dementia, Mental Health, and Cognitive Disability. Both organizations provide high-quality services for individuals living with or at risk for living with dementia. She's also the past president of the Allen Cognitive Network, having trained and mentored thousands of healthcare professionals, students, and caregivers on the use of the cognitive disabilities model, also known as CDM. She's worked extensively with the author of the CDM, Claudia Allen, whom she'll talk about, I believe, today, and used the model in clinical research, program development, and in education in a variety of settings. Dr. Cornell received her doctorate at Creighton University, where she focused on dementia care and lifestyle medicine, and studied occupational science at the Karolinska Institute. She's a graduate of the Brain Longevity Therapy Training Program through the Alzheimer's Research and Prevention Foundation and is a certified Montessori dementia care professional. And I am going to stop talking now and let her begin. Pat, thanks again for being with us today.
Well, thank you, Caitlin, and thank you everyone for coming today and taking the time to listen to this important information that I'm so passionate about because of the potential it has to change so many lives. And today we're focusing around the use of the model in intervention for dementia. And dementia is a leading global health and social issue. And right now there's nearly 50 million or more people globally living with the disease, and 6 million here in the United States. We don't have an available cure, and it's growing. And just to frame this up again, we're going to look at some evidence, and personalized interventions can transform the lives of people living with dementia and their families. We can maximize cognition, decrease distressing associated symptoms, reduce crisis and improve safety, and improve the quality of life for individuals and their families. Now, last week we talked about the basic constructs of the model, the history, the underlying cognitive processes associated with behavior, and we described the 6 cognitive levels. And today, we're going to, again, review a little bit of that, and then we're going to describe the basic intervention strategies related to the 6 disability levels related to dementia and cognitive impairment, and cite some examples. And I'm going to highlight some supporting evidence used in the model as it applies to dementia. And all throughout, I'm going to emphasize the importance of the role and benefits of caregiver training in planning effective interventions for the individuals living with dementia. And today, my hope is that we can really cover the span of what is the clinical utility, and hopefully you'll be able to get an idea of how this applies and some flexibility with the use of it, and also how we can use this in organizations or with individuals. So just a quick review, the cognitive disability model is a theory and evidence-based practice model that guides evaluation and intervention with people who have cognitive disabilities. And really, it's a very holistic model. It offers a way to understand human behavior in a holistic context, and it can help us to predict patterns of behavior. And in doing so, we frame that as a biopsychosocial approach. And Allen and her colleagues describe this in this picture, the can do, the will do, and the may do. And again, we talked about this last week with the Tippett man, balancing these three elements, where the can do is what the person is biologically capable of doing. The will do, we talked about what the person is motivated to do, but also today we are going to talk about, we're going to get into behaviors, and we're going to be able to distinguish a little bit. Is it something that they can't do or that they won't do? And then also the may do is where the caregivers come in, and the environment. So how the physical environment and social environment supports what the person can do and what they will do. And again, when these are out of balance, the person has a higher risk of dysfunction or accident or injury, and the behaviors. So here are the 6 cognitive levels. They're hierarchical, with 6 meaning no cognitive disability, and level 1 is significant cognitive disability. And as you see to the right on this slide, that there is a hierarchy of sensory cues. So we can also look at abilities in a hierarchical level, as well as how the person processes information and how that is translated into function. So a quick summary, it's an ordinal scale, 6 levels with 27 modes of performance. And within those 27 modes, we see that as cumulative. So in theory, if a person can do something at level 4.2, then in theory, they should be able to do everything below that level. The model identifies abilities and restrictions simultaneously. And Alan always called it a cognitive disability model, because she said people really wouldn't understand what she was talking about, but it really focuses quite a bit on abilities. And again, the model looks at learning and the process of cognition, and it understands global brain functioning, how the brain works as a total unit and how the parts of the brain work together. We also have a lot of contextual factors that are considered here. So when we do our assessments and we interpret this model, we can look at it in a variety of contexts that make sense for the individual. It offers guidelines and for care, and a lot of information to predict function. It's based on developmental theories, as we talked about last week, Piaget being one theory that informed the hierarchy of sensory motor development, and it's standardized and well researched. So before I talk about this, I just want to say that there is a wide range of how this model can benefit in clinical practice. Again, we talk about that important of the caregivers, and frontline caregivers, family caregivers can understand the model, understand their loved one, know how to communicate with them. However, as this slide depicts, and I won't discuss all of these, there's probably many more, but these are some of the high-profile safety issues that we encounter as a person progresses through dementia. And therefore, with the model, and we're looking at these important areas, we can look at the importance of skilled standardized assessment, skilled observation, and interpretation of those assessments. So here, again, we talked about some of the common assessments of the Allen Cognitive Level Screen, the large version and the smaller version, the Allen Diagnostic Module, the Routine Task Inventory, and Skilled Observation. And again, we can define that functional cognition influences how an individual uses and integrates thinking and processing skills to accomplish everyday activities in clinical and community living environments. So the interpretation, I want to say one more thing, is that we don't want to forget the person-centered approach to this as well. And this is going to become really important in today's discussion, because looking at the persons, we can look at their history, their culture, their educational level, where the person lived throughout their life, physical and environmental preferences, what they like to do for leisure and communication. But also what's highlighted here in red are emotional and behavioral reactions. So if a person has always been high strung or impatient and didn't like waiting in line, when they start to have a cognitive decline, you may see that behavior come to the fore. And it might exacerbate, especially if they can't remember what's happening or coming and they're waiting. Another example will be sensory likes and dislikes. And when we look at those hierarchies of sensory cues, the sensory approach has become critical in being able to communicate and reach people as they come into the lower levels. Habits and routines, again, are critical. We talk about procedural memory, but what is familiar to the person. And as their cognitive level changes and they have less flexibility, they look at their habits and routines and they engage. So we can tap into that to improve engagement and function. And again, personality and coping styles influence how behaviors are expressed. And in interpretation of all of our assessments, we consider cognition in a dynamic process. So we know that there are regular patterns of performance, irregular patterns. We can look at someone having a consistent or functional gain if they've had maybe a temporary urinary tract infection and now they may improve, or a functional loss due to their disease. And just to review from last week, we noted that cognition is influenced by a variety of things: stress, illness, fatigue. We are looking at who's getting good sleep. We know that the energy of the individual, everyday activities could use a huge amount of brain energy. And the lower someone goes down on the scale, the more energy is required to do things and the overall threshold for what they can do in the context of a day. So it's a very dynamic way of interpretation. And Alan talked about the role of activity well ahead of her time. And in the foundational framework, she talked about engaging current cognitive and functional capacities is valued activities with worthwhile therapeutic objective. And her premise was that she was concerned about people being misunderstood and spending long hours of sitting around without much to do. So again, I'm showing this picture to give an application of what it could look like in engaging in a meaningful activity tailored to ability. And when I talk about Alan being ahead of her time, years later, here's a study and many more coming out after it with the Taylor's Activity Program. And that's based, this is a program based on remaining abilities and modifying activities to the person's ability, training the caregiver, and using the Allen theory as a base. So again, activities were tailored to interest, educational level, personality, and they were prescribed. They called it an activity prescription. And the premise was to reduce behavioral symptoms and increase engagement. And the original study was done in the home environment. And the authors cited that challenging behaviors was a main reason why individuals may be placed or go to an organization. And they cited it as caregiver stress. So in this particular study, they had 8 sessions over 4 months, 3 phases where the abilities using the Allen assessment tools were evaluated by the occupational therapist. Meaningful activities were tailored to capabilities, and the caregivers were instructed on strategies, but they generalized the strategies to other care activities. And the result was that the behaviors decreased, but also the caregivers felt less hours on duty, and they felt more competent in being able to assist their loved one. So again, this study really highlights the fact of caregivers. And as they were addressing the behavioral challenges or the neuropsychiatric symptoms of dementia, this is a huge thing in what we use the cognitive disability model. So we know that these symptoms impact individuals living with dementia nearly universally across the stages. They contribute to a decline in functional activity, an increase in healthcare costs. They can be aggravated by physical and social environments that don't match abilities. They're the main reason for placing individuals in long-term care, and they contribute to caregiver stress and staff burnout. And I put this slide in here because COVID-19 has exacerbated behaviors. And in a systematic review, several authors described significant worsening of the neuropsychiatric symptoms, including depression, anxiety, anger, agitation, and insomnia. They really attributed that to the isolation. So isolation from family members, social restrictions, and restrictions of non-pharmacological interventions, which are one of the primary first-line interventions for dealing with challenging behaviors. So also they cited abrupt withdrawal from social contact, which resulted in anxiety and trauma. And they have noted that that has been found to accelerate cognitive decline, as well as increased levels of distress in caregivers and nursing home staff, and increased risk for self-injury and hospitalization. And in particular, they also noted that there was quite a bit of anxiety related to isolation dominating the clinical presentation in women in early onset dementia. So, and maybe later we can have more discussions about this and what's happened currently, contemporary in our population here. So I'm going to move into this connection now of the behavior and cognitive link, and I'm going to be highlighting some work of Delon Pollard, who is an occupational therapist in Australia. She has worked many years with Claudia Allen and traveled many times to the United States and has contributed quite a bit of a work and knowledge in the area of the cognitive link with behavior. And she writes that when a cognitive deficit is evident, bodily behavior becomes even more difficult to handle. And here's an illustration. As you can see here, the 6 cognitive levels are representative, and you can see that just the hierarchy of processing information from low to high. And Pollard talks about the degree of behavior expression is related to the person's cognitive level and their personality traits. So, and this was like the aha moment for me when I started recognizing this, because I studied and I learned the model, and I learned all the precise levels of ability and function, but I also started to see it through a different lens, that no two people are alike. And that was based on seeing who they were as a person and what their personality traits were. And again, if you look at this slide, the physical and emotional overlap, but again, how we're going to understand behavior and how we're going to help with our interventions relies on how the person processes the information and what their personality traits are. So here's a great little quote that says, when the mind is not available to influence behavior, we can use sensory input. And what that means is maybe someone who is in level 3 is having a distressing day and asking repeating questions, or pacing or wandering. And what we know is maybe we can't talk that person out of that or talk them down. They might not be able to process what we're telling them, but we can use different sensory strategies and input to that nervous system to help influence their behavior and their outcomes. So Pollard also coined this the fragile sense of self, and she said that the fragility of self will become apparent when brain processes begin to break down. So both emotional and physical behavioral reactions occur to save the fragile sense of self. And again, that was another aha moment in terms of working with individuals, because how we communicate, how we present our tempo and our personality to a person can make a huge difference in terms of not having them feel threatened. And even sometimes, if out of kindness we're over explaining something, it may be above their cognitive level, and they may just say, I don't want anything to do with you, because they can't process that. So starting with the 5 levels, I'm going to review some of the profile, and then I'm going to go through some common behaviors and some general intervention strategies of what we can do at each level. And in level 5, again, independent learning, which is associated with mild cognitive impairment, generally associated with the GDS or FAST scale, stage 3. Some people will progress to dementia, but not all. And information processing begins to slow down. Working memory is affected by the person's ability to reason, and the person may show difficulty with multitasking, task switching, judgment, and executive function. And what this can look like in abilities, mainly they're going to learn, use trial and error for learning. And in some of their cognitive and functional challenges, they'll have difficulty with novel and complex tasks, maybe anticipating and planning. This is where we said they could be viewed as impulsive, difficulty with abstract ideas and seeing the whole picture. Some of the behavior challenges may be viewed as difficult, manipulative, criticizing others, feelings of self and personal rights. They can be insensitive, blunt, or frank. They may have difficulty understanding other people's health or emotional needs, and they may give ultimatums and blame others. So here are some basic interventions. We want to show the person the pros and the cons so they can anticipate what an outcome may be. We help them with goal setting and follow through, offer cues to stay focused, time management skills, and a schedule. Offer them assistance with novel and complex tasks, offer concrete safety instructions. This is a great time for memory aids. And again, supervision with new ADL methods. And even abstract ADLs like energy conservation may need extra explanation to help them understand. And here's an example. We could go through the whole scale like this today, but we don't have time. So I wanted to point this out and show you how specific you can get with the scale and coming up with strategies. So at level 5.4, a person may not anticipate predictable changes. And we say seeing is believing. You may be able to tell someone you're having back surgery and you're going to have trouble bending, and you may need to sit on a bath chair or use a grab bar, and they may say, well, I never had to use a bath chair. I'm not sure where that bar would go, and I don't really always know why I need that. They may accept a change after the undesirable effect, and there may be power struggles in that interaction. And also the person may underestimate time at this level. So again, we want to assist with planning. Weekly checks are really helpful at this level. And to avoid the arguments, you can use phrases like, tell me what you think, or let's have a look, or maybe this could happen. It's happened before. And I think that this is a great way to think about avoiding this consequence and identify that in very simple and concrete ways. And another very, very important thing at this cognitive level is to promote a healthy lifestyle. And there is just such a large body of evidence showing that healthy lifestyle choices can reduce the risk of dementia. And maybe we can even help people in mild cognitive impairment not to go into the full-blown dementia. But before I explain this, I want to say that this is important for all of us, not just if you have mild cognitive impairment, because the research is now showing that especially with Alzheimer's disease, some of the changes in the brain and in the disease process can start as many as 20 years before the symptoms are expressed. So again, we're looking at regular physical activity, management of cardiovascular risk factors, healthy diet, which is, they talk about Mediterranean diet, DASH diet, avoiding processed foods and sugar, healthy whole plant food-based diet, lifelong learning, cognitive stimulation, social connection and participation, and managing sleep and stress. And I recently worked with an individual diagnosed with mild cognitive impairment, and he was retired and had depression and on the verge of being in and out of the mental health unit for his depression. And this is what we focused on as part of his intervention, working right from the beginning with his caregiver and selecting a method of looking at a daily planner, a schedule, and reviewing that every day in a habit over coffee and what's happening today. He was very receptive. We gave him education about brain health, and he was very receptive to the physical activity. And we, in order to ingrain that as a habit for him, his son agreed to come over and walk with him a few times a week. And he was a retired salesman and very extroverted, and had agreed to go to a what we call a Toastmasters club, which was a speaking club, where he had a lot of cognitive stimulation and social connection. We went once a week. And again, we addressed his patterns of stress and promoting education on sleep hygiene. So that I can't say enough about how important it is for all of us to address those brain health all the way through the dementia stages, but particularly level 5 is important. Now, level 4, we're talking about goal-directed activity, and this is generally associated with the GDS and FAST stages of 4 and 5, and there's a moderate cognitive decline and moderate to lead to severe cognitive decline. Procedural processing remains intact for familiar activities, and difficulty processing verbal, visual, and contextual cues are present. They have some difficulty with inhibiting irrelevant cues. So they respond best to the external concrete visual cues. And what this looks like in abilities, they can sequence through the steps of a familiar activity. They can complete basic familiar self-care. They're focused on eternal events and time in increments of an hour, which I'm going to share a case study in a minute, but that is a critical feature. Also, some of their challenges include verbal skills can mask functional skills. And this is so important for the whole team. Just because a person can tell us what to do doesn't mean they can do it. So yes, I know how to drive the car. Yes, I know to stop at the traffic signs, but that doesn't mean that they can do it. There's a different set of brain processes in doing versus saying. Maybe they tell the doctor, I haven't had any falls, and yet maybe they've had 5 falls in the last week. So they're starting to have some memory lapses, and they're filling in some of that memory lapse with language. The thinking is concrete. They have problem-solving difficulties. Visual perceptual skills are changing. We talked about last week that at 4.6 is when they can scan the whole environment and perceive the environment behind them. But as they come down the scale, they're looking at 3 to 4 feet in front, then the dominant side, then right in front, and viewing everything more and more closer and in front as they go down the scale. Some of the behavioral challenges are interrupting, asking repeated questions. They might not understand why things are done. So if we look at basic interventions, again, striking visual cues. Those are recognition cues. It's the difference between a multiple choice test or asking someone to write an essay. So they like the recognition cues. They need items in plain view. It will cue them to remember to put their hat or their sunscreen on before going out in the sun. They need assistance for sequencing new activities and generally avoid written and diagrammed instructions. We can offer cues to notice errors and provide a structured routine with meaningful life roles. And safety assessment and interventions become critical. And this is a level when people have more prominent safety issues in terms of independence and living home alone. A lot of people are still driving a car. And again, many, at this point, they should be stopping to drive a car. And so we need a lot more safety assessment and intervention. And for an example, again, at the social consequences at 4.4, people might not like being told what to do, or they might protest. They may demand immediate requests for attention. They're not able to understand those social directives about that and the context that they're in, and they may have difficulty perceiving personal space of others. So we need to simplify, we need to repeat. This is a time to think about guardianship. Actually, we probably should be thinking about this sooner. And the beauty of this scale is that we can anticipate and predict, and also coaching and advising on taking turns. So before I go to level 3, one example of someone who I worked with in level 4 was a lady who stopped doing everything. She wouldn't get out of the chair, and she was becoming very deconditioned. They ordered occupational and physical therapy for her, and she refused everything. They tried to do the assessments. She said, no, I'm not doing it. So they called me in to help. And through skilled observation, I surmised that she was probably in level 4. And in having a discussion with her, I just asked her why she was sitting all day in her chair. And she said about a month prior to that, she went to the eye doctor in an hour-long car ride. And the eye doctor did some tests that aggravated her vestibular system. And she was sick to her stomach and had vertigo all the way home. Well, she felt that after that, she needed to rest. And again, we know that people at this level perceive time in increments of an hour. So she wasn't able to perceive that time space and to perceive that maybe I'm okay now and I can get back to my routine. And just understanding that little bit of information and how she may be processing it, we were able to revise the way that we communicated with her, how we presented things concretely, engaged her simply, stopped offering explanations that overwhelmed her, and she was able to participate, especially in her physical therapy exercises. And when we move now to level 3, this is manual actions, and it's generally associated with the global deterioration scale and fast stage 6. So we're having a more severe cognitive decline. The person has lost the awareness of goals and outcomes. They're engaged in repetitive actions. Familiar objects that can be touched and tactile cues promote that attention. And they can be easily overwhelmed by excess stimuli. So again, we're coming down that scale and they're more overwhelmed by the stimuli. What this looks like is they benefit from following cues to the next step. They like to manipulate objects. They'll notice people and objects again right in that front visual field. And they may attend up to a task for a half hour with support and cues. And they are relying a lot on procedural memory. And in their cognitive functional challenges, they have difficulty understanding verbal information, and they're not likely to ask for assistance. In behavior, we can see agitation, combativeness, elopement, getting lost, disrobing, sundowning, pacing, wandering, and calling out. And this is how they are communicating and getting their needs met. So some basic interventions, again, are cues to begin, continue, and end. And those cues should be simple phrases and one step, but augmented with the touch, the tactile cues. I find in working with these people, before you step into that encounter, and this is what we work with caregivers on, is you take that deep breath. You slow the pace to their extra time and their rhythm. And the less language sometimes, the better. So less language, more tactile, and extra time to respond. You want to avoid the use of pronouns, minimize those distractions, one-to-one sequencing and setting up a task, and simplify the task to preserve a role. So again, here's that famous picture again. And if these ladies are functioning in level 3, they're polishing apples, doing a repetitive motor task that is structured so it doesn't involve sequencing, but it represents a past familiar role, gives them a sense of self. And an example of a specific behavior at the middle of the scale, the person dislikes being told what to do and they can't understand why. They lack the ability to judge the effects of their action. So again, we want to work with the caregivers to assist and encourage with self-care and recognize that they can't be left alone. The caregiver training is to help the person shift their actions for sequencing. And the story behind this is, I'll show this slide as I tell you the story, as a lady who was in a facility in this cognitive level and was really upset and agitated. She was striking out and hollering. Her son stopped coming to see her because he didn't know how to communicate with her, and they didn't know what to do with her. So we started with a personal profile to find out what her interests were, her habits, her routines, and she liked Elvis Presley music. And when they asked me to go see her, I knew I had to get right in front of her to capture her attention before I was talking. And her care staff was trying to reason with her about why I was coming to work with her. She wanted to go to bed, and you could just see that verbal overload was creating all this agitation. So when I got close up to talk to her, she was angry, and I wasn't quite sure what her reaction was going to be. So I very calmly said to her, "So you like Elvis?" And I paused. And from there, the world opened up for her. She just started talking. Where are my records? Where is this? And from there, I could realize at that time that maybe the environment and the caregiver and the families were universally overloading her with language that she couldn't process, and it was causing the agitation. So what we did is we took a lot of the language out. We worked with her son on having meaningful visits. We worked with the caregivers on how to tailor those activities to her abilities and interests, and we were able to have a positive outcome in her engagement. Now, another challenge we have at this cognitive level is what is depicted in this picture, where individuals have periods of time where they're sitting. And the challenge with that is that they can't hold information for long periods of time. Even on the lower end of the scale, it's less than a minute. So the way they're perceiving this could be like eternity. They don't know, they can't remember what happened 5 or 10 minutes ago. They can't perceive that lunch is coming in 20 minutes. So they're kind of just hanging out in space. And what we can do is offer, again, they like to touch and feel and manipulate things. There's activities where you can get, we call them rummaging or activity boxes, and putting objects that are meaningful to them and fostering some reminiscing around that. objects that capture their attention in the environment, and sometimes we have to direct them to those objects. But and we don't have time to talk about all of this today, but there's a lot of studies and researchers that talk about balancing that, the uptime of stimulation with the downtime of lack of stimulation, and how that can help to modulate aggressive or distressing behaviors. In level 2 now, that is postural actions, and it's generally associated with the GDS fast stages 7, and that is severe cognitive decline. The focus is mostly on internal cues, sensations, and proprioception. The person is focused on comfort and movement, and the objects no longer serve as recognition cues. And in level 2, they have a lot of abilities that sometimes caregivers really struggle with on what to do. And those can be gross motor movement. They focus on comfort. They're aware of body parts. They may use yes or no. They're able to initiate those actions related to balance and postural security. And again, focusing on movement, touch, and sounds. This is where a lot of the sensory approaches become critical. And in the functional challenges, they have difficulty perceiving themselves separate from the environment. So this, again, when we work with caregivers, sometimes caregiver is the window to their world, becomes really critical. And again, meaning of objects is lost. They can express themselves with behavioral challenges in agitation, fearful, resisting care, hitting, kicking, pinching, postural insecurity and fear of falling, and calling out. Some of our basic interventions include proprioceptive cues, and proprioceptive cues are providing deep pressure touch into the nervous system to help them orientate where they are in space. And again, they're having a decreased proprioceptive feedback loop that makes them feel insecure when they change positions. And in particular, I have found very, very helpful to give them just some gentle hugs, gentle input before you ask them to change a position, and give them extra time before they stand or change position. Single word directives, and then again, keeping things familiar with repetition. And sometimes that can be accomplished with music and getting them feeling comfortable and safe before you ask them to do things like standing. A calm environment with sensory approaches, generally 10-minute one-to-one activities can be successful. And again, functional activities to promote movement. So here I'm showing this slide again, that the sensory modulation programs, and we can look at this at a deeper level of balancing the uptime and the downtime, but using a large ball for gross motor activity can capture attention. Here's some sample activities that I wanted to include because people don't always understand what they can do. So again, here's some massage, scented lotion, singing, music programs, using a rocker, chair, and glider with supervision, assisted walking, sometimes pets, intergenerational activities, and sensory quilts. So here's a few examples. And I also included this in this because it's the progression of the gross motor skills. And it's just an example of how this scale looks at the hierarchy of abilities. And again, as this can be used when you're working with people to say, well, what can they do? And what kind of activity can we structure based on their gross motor abilities? And here is a consequence at 2.4. Walking requires all of their attention, and they're unable to initiate or continue resting. So we can offer seated rhythmic movements with supervision. Again, those gross motor movements with music to maybe prevent that aimless walking and then getting fatigued. And again, supported sitting with intervention to remain seated. And boy, I've worked with a lot of people in level 2 who had a lot of distressing behaviors. One woman in particular was crying all day, and the staff was spending at least an hour a week trying to understand what to do with her. And what we basically worked on was allowing her to have extra time to process changes in position, changes in, she required 2 people helping her with her self-care. One, she was combative, so one to hold her down, one to get the job done. She was crying all the time. And what we found was when we offered those proprioceptive cues, train the caregivers to slow down, we use familiar music, she was able to participate. And actually, she was able to get up in one treatment session with a little music and input to stand and walk. And based, the nursing staff just couldn't believe that this lady could walk like that. But based on that, we were able to build a program out of her ability to walk, pushing a cart to give her sensory input and some neuroregulatory input to calm her down, as well as maintain her physical function. And finally, in level 1, we have automatic actions, and that is pretty much very severe functional decline, minimal response to the environment. The person's attention is limited to subliminal or internal cues, such as pain, hunger, smell, and taste, and actions are done in response to comfort and discomfort. At this point, again, they're focused on internal and comfort, and they're using their senses to respond to stimulation. It's significant functional loss, and they're easily overstimulated, and we're working on total comfort care and support, as well as they may be striking out at caregivers, they may say no, or slump in their chair. So here's some basic interventions. Again, calm environment, avoid the bright lights, loud noises, frequent human contact, limit the visitors to 1 at a time, move slowly and gently, 1 or 2 sensory inputs, one-to-one stimulation programs, positioning and range of motion. And here they're not able to self-protect, they're not able to position themselves, and they have a heightened response to the sensory stimulation. So we need to protect them. We need to offer positioning and also sensory-based treatment that is personalized. And I think that is probably one of the biggest takeaways on level 1 is because we worked with a lady, and she stayed at home throughout her whole dementia. And when she became, when she was in this level, we used a personal profile and developed a whole program where she still had the ability to turn her head and track stimuli. And her family sang her favorite Irish songs next to her, and she was able to turn and look. They massaged her favorite scented lotion and integrated a program like that. And not only did she respond, and again, we know that sensory information is embedded in the nervous system, but the family felt comforted by the familiarity and the connection with her. And I'm going to go through a few slides now just to talk, kind of connect the dots for the falls, because falls is such an important concern with dementia. It's been found to be an independent risk factor. People with dementia fall more than people of the same age without it. And where it's related to impairments in judgment, visual spatial perception, gait, the ability to recognize and avoid environmental safety hazards, and motor planning. And the prevalence increases as cognitive impairment increases. And it's a big challenge for many caregivers. There's a study out that was built around the tailored activity program. This was a feasibility study using a tailored approach for evidence-based fall reduction strategies, and home hazard reduction. And the Allen Cognitive Disability Model was used to understand, using the Allen Cognitive Level Screen and the ADM to understand the person's ability and match the interventions and tailor them to their ability. Was conducted in the home environment, and again, modifying evidence-based approaches. Again, this was just a great example of a practical application that we all can do in evidence-based practice by modifying our task analysis and looking at the person's abilities. So just a few slides here. Falls and mobility, level 5. Again, it starts in level 5. So we know divided attention and dual task analysis and executive function are all things that can impact a person's safety and gait and risk for falls. So we need to help them anticipate hazards, consider seasonal challenges, make sure pathways and walkways are clear and there's adequate lighting, monitor medications that contribute to fall risk, and supervise when the person is ill. In level 4, we want to modify that physical environment to accommodate those visual changes again. As they come down the scale, they are not looking at all and scanning the whole environment. Depth perception starts to be impacted. We can do long-term repetitive training for strengthening and range of motion. We can cue to sustain changing their pace, and they're not reliable with weight-bearing precautions. One study was done a while ago, but they were saying people at 4.4 and below were not consistent following their hip precautions after surgery, and they found the most reliability occurred after 5.4. But we have to recognize that in this level, and we want to train in the context they'll complete the task. In level 3, again, for exercise, several short sessions throughout the day is great. They're going to rely on procedural memory for activity. We're going to consider that their visual attention again and what they notice. They will not remember safety precautions. We want to supervise them, escort them to new and unfamiliar locations. They can easily get lost, supervise on stairs and uneven surfaces and with walking devices. We want to cue the person to change body position and, of course, remove the hazards. And here's an example of a gentleman who is in level 3, and he's doing repetitive exercise with supervision. His therapist was in the background, and he just loved this exercise. He went regularly. But what's so nice about this is that the exercise gym in the clinic was not busy, and it was not overstimulating, which would distract the person's ability to focus their attention on doing their program. And finally, in level 2, person's not likely to use walker or crutches or a cane safely. We know at 2.4 is when they're walking on flat surface, and 2.6, they are going to be able to lift their leg up maybe onto a step or over the tub. So they're going to need assistance and support for all transfers, supervision with wheelchair use and walking. We want to eliminate all hazards and unstable surface furniture because they might pull up and grab on that. Again, prevent that fatigue, dress and bathing in seated positions, and really guard against safety on the stairs. And again, walking is more automatic, have maybe pushing a cart. And finally, moving into the end of our discussion here, again, we talk about the importance of caregivers. And again, the research indicates that education and support increases the chances of adherence to treatment recommendations for patients. But caregivers also experience a high degree of anxiety and stress. They have health-related issues. In the United States, we spend $257 billion on unpaid care. 2/3 of our caregivers are women, 30% are 60 and older, and 60% are the spouse. And one thing we can consider with caregivers, again, is what is their role and is their role changing? So if one spouse has dementia and managed all the finances, Now the other spouse who maybe never did it had to do that, or other activities like cooking. So we consider that, and studies also show that the grief that caregivers experience is actual grief. It's not anticipatory grief. It's actual grief, as if maybe the person has died. So a lot of things to really consider with the caregivers, and studies also showing that with caregiver education, we have better outcomes with the individuals. And this also applies to direct care staff and paid caregivers. There's a high degree of turnover and burnout as well. And also studies indicate that education has better outcomes with retaining those caregivers. So I just wanted to take this. So we've talked a little bit about the application with individuals, and now we're going to talk about a broader perspective. It goes back to that biopsychosocial can do, will do, may do. And what I say when addressing behavior, I kind of coin it two ways. We can look at, sometimes people will want me to come in and say, hey, this person's not bathing. Can you do something? And they want a focal approach. But sometimes there's a more global contextual disruption for the individual that makes it more difficult to help them work through those challenging behaviors. So basically, I'll just briefly go over some of the things we do are an organizational assessment. We look at strengths, we look at what their training is, we look at where their community support is. I come in and look at all 24 hours, what the temporal rhythms are, what's happening at 7 at night and what's happening at 7 in the morning and 3 in the afternoon. And then we go through an evidence-based education and training in small and larger groups with on-site mentoring so people can learn side by side. And I have found that showing people how it can be done, showing the caregivers how to get a person engaged has been, I've had more success in having carryover and sustainability. We work on building partnerships with the family and caregivers and inviting them in. And again, measuring participation and satisfaction with the program, skills and confidence of the learner, and looking at tailored outcomes to that organization. Some of my work and research has focused on patterns of engagement, and for many years trying to help people say, well, what is it that you see? And how do you look? In one study, it's like we were interviewing therapists who were really skilled in this model, and how they were viewing patterns of engagement versus people who weren't using the model through that lens. But again, we measure throughout the day and in different contexts if a person is positively engaged, neutral, or negative. And we can kind of track how our implementation is coming. We also, I recommend using some type of standard guideline. There's many out there. This one in particular is a dementia performance measurement set that is based on, it's not meant to be guidelines, but it's intended to facilitate quality improvement activity. And again, sometimes there's so many complexities. People are coming into the system when they're in a crisis. Sometimes they don't have a diagnosis or have that addressed to later on. So we can look at all these areas as a team and say, where are our gaps? But in particular, number 2, education and support of caregivers. These This was an Academy of Neurology and the American Psychiatric Association collaborated with top organizations. And again, they really emphasized that the caregiver support and education was critical, so much that they refer to it as the patient caregiver dyad. So we use that. And then one example here is in a organization, we did a pilot program with 4 buildings and basically used the tailored activity program as one of the guiding studies for our application. but we trained everyone. We trained the team together. We trained the administrators. Everyone had functional cognitive assessment. Everyone had personal profile to find out what was meaningful to them. And then we structured the day so that we were balancing these routines. So, and what happened was we did not focus on fall prevention. We didn't focus on any of these things here. We focused on quality of life. And we noted that all 4 buildings had a 2/3 reduction in falls that maintained for 2 years. The challenging behaviors were significantly reduced. Less medication use was reported. And also, the staff reported less issues with weight loss and less use of supplement. So we were pleasantly surprised when we started looking at some of those outcomes. But the staff also reported a great deal of pleasure and happiness, really, in seeing how they could engage people, and also seeing that people could have times of feeling happy and purposeful. One more quick, the adapted work program. This was back in 2004, program from the Minneapolis VA that was influenced by the cognitive levels. And basically, this was with gentlemen who were retired veterans who were home and having some challenging behaviors and looking for meaningful things to do. So the hospital developed a program where they came and they did repetitive work activities adapted to their ability. The hospital had a budget cut, and they noticed when the program closed that they were having a faster decline in their abilities and cognition. So they did more study and basically said that promoting the active engagement versus passive engagement was having overall health benefits and improvement. So based on that, in another program, we offered an adapted work program for people functioning in level 3 and 4. And this was a memory care assisted living unit. And every day, actually, when we were hired to do this, there was not a budget for activity therapists. So we had to create our own program. And we had a routine every morning. They would walk to breakfast and they would have seated exercise, rest. Then they would come in the morning and do these activities that were modified to their ability and interest. And again, this gentleman was a businessman, and he did several different types of activities like folding and stuffing envelopes and punching holes in paper. And here's another example where we had the local funeral homes deliver bouquets that were donated by families, where we disseminated those bouquets, and we were able to break the task down for levels 3 and 4 and make new bouquets. And some of the goal-directed individuals would put them on a cart and deliver them to people who were in the nursing homes. So, but in this program, again, we did not have a lot of falls. We did not have a lot of challenging behaviors. And 8 months into it, the director was so pleased that he hired activity people, and they came in and they changed the schedule. And what we found is people were kind of standing around and saying, well, where's my exercise program? Well, where's this? And I said to the director, because in my experience, it's about 3 weeks to build those habits. If you don't hurry up and have them work with us, and you're going to undo all that great work that we developed in the last 8 months. So long story short, we got the whole team on board, and here's some examples of how they've modified dining rooms in physical environments. So with that, I will conclude my presentation, and we can take some questions or discussion.
Thank you, Pat. Actually, I do have some questions here. The first question, well, actually, one just popped up here. One person who is an occupational therapist says, I don't have a specific question, but many. Now that I've worked with a lot more clients with dementia, as well as have had my mom move in with me with early stage dementia since October, I want to study and train in this amazing model and share with everyone I know. Your training is wonderful, it's beautiful and amazing, and I'm ready for so much more. Do you want to piggyback onto that and tell her how she might get more experience in this regard?
Sure. Well, thank you so much. And first, I want to say best of luck with your mom. I've been through it with my father. So, and for training, we have programs at Vita Cura, and we're going to be offering. We've had such an overwhelming response, especially during COVID. So we are going to be posting. We're going to have some webinars and a foundation course, and also some, I guess I'll call it study groups, but more for people who want to come together, who have some experience with the model, but to know how to take it with specific people they're working with and be mentored in collaborative models. So you can email me, but we'll also be posting some information in the next week or two on the website. So
thank you. Another question is, can you speak about why not to use pronouns? You had mentioned that earlier.
Yeah, it's too abstract, basically. So it's better to say, instead of saying, it's better to say Mary, like your daughter, or he or she is too abstract and they might not connect what you're meaning.
Another question, what are some ideas for meaningful activities for adults who are blind, maybe level 4 or 5?
That is a great question. And where I would start with that first is, how long is this acquired blindness? Is it something new, or have they been blind for a period of time? Because I would start with a personal interest checklist or profile to find out what they have done in the past, so that you could tap into what's familiar and modify it. But if it is, I think you have more of a challenge if it's a newly acquired blindness, because now you're going to have to help them learn and cope with it. So I say, when we look at the scale again and we look at those hierarchy of sensory cues, we know that everyone can respond to the lower cues. So proprioceptive input is essential for someone in level 2, but for me and you, it's really helpful as well. So what it does, it's a neutralizing input. It helps us feel calm if we're anxious, or if we need a little bit more energy, that input will kind of bring us up. So you could start thinking about it from a sensory perspective, and that could be music. I mean, that might be a wonderful place to start. And then assessing what their abilities are and their past skills, and then you can move into tailoring that to their ability. So I hope that helps to get you started. There's never a cookbook with this model. That's what makes it so interesting.
And here's another question. At what stage does lack of recognition of family begin?
Well, I think it starts, in level 3, but we also know at 2.0, someone will have a heightened response to loved ones. And I get this all the time from caregivers, the distress, like, I come to visit Dad and I don't think he even knows I'm here. And the way I explain it to loved ones is to say, but they might not recognize you in the sense that you always knew them to recognize you, but if you stopped coming, how would they feel? And I think even as we get down to the lower end stages, again, they feel the emotion, they feel the love, they feel the connection. And I say we work really hard with family members to show them how to have meaningful visits. And I'll be happy to share, I have a scale for that in the lower levels of how to have meaningful visits and teaching families what they can look for that's meaningful.
We addressed blindness, but how do you modify for the hard of hearing? And how does hearing decline affect those with dementia?
Oh, that's a great question. I'll start first that now we know that we'll go before they have dementia, that now they're saying hearing loss can contribute. It's a risk factor. And what the researchers are looking at is because not directly correlated with it, but they're saying that people with hearing loss have sometimes they're not socially connected, they withdraw, or sometimes they're not getting enough information into their brain from the sense of hearing that's going to stimulate that cognitive development. So if someone has a hearing impairment and they have dementia, the first thing I would say, do they have their, make sure they have a hearing assessment, a hearing aid that they can maximize that for sure. But again, even as a person advances, we know that we have to simplify our verbal expression, and people are going to benefit from those tactile cues and the sensory environment as well. So we want to really be extra aware of how we're using those other sensory cues of tactile and movement that may help keep them connected in the doing.
Well, and speaking of sensory, how do you cope with somebody who has dementia, but also has a long-standing history of sensory processing disorder? How do you work with somebody like that?
Well, now that's another great question. And it's, I say it's not easy. I say that's where I go back to having a toolbox of our skilled assessments and our skilled observation. But if we're looking at sensory processing disorder in general, what are we trying to achieve? Regulation. We want to help someone feel balanced. And boy, goes beyond the scope of this talk, but there's a lot of studies and theories, and I do a class on this, the model of sensory stasis with people with dementia and how to balance uptime, stimulating time with downtime. And again, it's not a recipe for all, but with someone who has additional challenges, then we have to tailor it. And again, of course, look at the whole picture. And I talk about a focal picture with the person, but that global environmental context as well, which can help the person overall to feel more balanced and more adjusted. And I just know I've read studies where noise in and of itself can be one of the leading causes of agitation with people with dementia. So that is a great place where you could start to just see what the noise levels are for a person.
Right. Related to sensory, you mentioned hugging earlier. Can you talk about ethical guidelines regarding the use of hugging, particularly, people who have dementia?
Well, yeah, that's I know it got harder even during COVID. But again, we use a personal profile, and one of the questions asked is about touching and hugging and their preference there. We find that out right away if someone prefers not to be touched or hugged. But in my experience, overall, I have found, especially people who are progressing in dementia, that the hugging has been something welcomed. But again, I would always check and make sure it's okay. But it's been welcomed, and even during transfers in these lower levels, even the caregivers are really offering a firmer approach so that the person feels safe and secure.
Do you have any experience and thoughts on cognitive stimulation therapy groups?
Yes, I think that, I've read some study on that, and I think there's many great activities and ways to encourage people to use their brain. And I think cognitive stimulation, again, tailored to abilities and interests that a person can actively participate in, is good for their brain health. And if you can integrate that with socialization, there are also studies that show that helps with sleep as well. So I think that they're good.
Also, would you recommend an on-road driving assessment for mild cognitive impairment also as well as for moderate?
Yeah, I would. It's usually about 5.6 is kind of the marker that they say for driving. And I think it's really, really important for clinicians, especially those who are using this model in a formalized way, to address the safety and the driving. And if a person, sometimes the challenge is, especially in level 4, if a person's in level 4 and they're still driving, they don't think they need to stop driving. And so sometimes if that's the case, an online driving assessment is recommended so that they can see that for themselves. Level 5 people still drive, but again, I think it's really important to start having that conversation with people. So we recommend it all the time.
Back to the sensory, with regards to sensory input, what do you think about tucking blankets tightly around the patient or the client?
Well, there's been studies about warm blankets and weighted blankets, and they've been beneficial. I'm conservative, so we recommend having a policy, especially with therapeutic use of weight. And some of the things, we sometimes even get a doctor's order for that, but the person you want to not confine them. So I think that would be the biggest risk factor, and they would have to be able to remove the blanket. But there's been a lot of benefit with swaddling and therapeutic use of weight. But I think it needs to be used in a clinically appropriate situation.
Someone wants you to provide an example, please, of where on a person's body to use a firm touch if a person is too agitated for a hug. Would it be their large joints, for example, the shoulder?
Yeah, and this is where, I don't know if you can see me on Zoom here, but sometimes if a person is seated, you can gently put a little light pressure into their knee or their hip. Like I tend to want to make sure someone's feet are firm on the floor, especially in level 2, so they can feel where their body is, and then gentle. It's very gentle, but it's just starting to put you can also do it this way, just little gentle hugs or into their larger joints. And that's one way where we prime a person to feel safe and secure before we attempt to try to get them to change position and stand. But you can do squeezes too with their hands, and
An OT asks, given new increased regulations on OT frequency in home health, AGM, yet the immense value and need of this model, what simple steps would you suggest to home health OTs who want to increase practical use of this model while carefully minding their time and frequencies?
Well, if this is in the United States healthcare system, I'm going to go back to that caregiver importance. And the ideal preference is to train the whole organization. But, and I know therapists have a fear of using cognition as their mode of treatment, but this is functional cognition. So we can talk about it from a functional safety perspective. And I would recommend doing a comprehensive assessment, developing a program, training the caregiver, and safety and education. And ideally, if you can get your team on the same page, then you're going to have a better supportive community-based approach, because we know that people with dementia will progress. So we need to alert the caregivers and the people in the home of when to maybe call us back in, or how to get help when those changes occur.
Have you got any advice for completing the assessment on generic hospital wards when it's a new and unfamiliar environment? And also, time is limited. What assessment, if time is limited, what assessment is the best to use to get a base for their level?
Oh, that's a great question. I mean, I have friends who work in the hospital say they don't have time to do the formal assessments, but they have a lot of skilled observation, especially in an acute setting, where they know they can start by meeting the person where they're at. I like, if you have time, I love the leather lacing assessment, because it gives you a broader scope, and it's quick and it's easy and it's portable. But some people say they don't always have time for that assessment. So you could do skilled observation, or maybe a quick ADM.
We have time for one last question, and I have it here. Someone says she attended an online session of the University of Pennsylvania's cognitive comedy, and that it was great. The participants engaged in improv and were hilarious, and it was extraordinary. What's your experience with something like that, where people are using theater skills or improv skills?
I don't have personal experience, but if people are engaging individuals and they're connecting, I think it's fantastic. And that there's so much creativity out there, and programs developing. Our most important thing is to have that skilled ability to make sure it's meaningful for each individual. And I would love to learn more about that program, because yeah.
Well, we've come to the end of our time, and I suppose we could probably go on all day. But what I would say is, if any of you have further questions for Dr. Cornell, she does have multiple resources on her site, and we will be offering some materials. We're going to be talking with her about whether it's recordings or slides or whatever it is. But Dr. Cornell, I want to thank you so much on behalf of Institute on Aging. This was another terrific, rich presentation, and I think we all got a lot out of it today.
Well, I want to say thank you as well, and I appreciate the opportunity to be sharing such wonderful information, and coming from a rich history of Claudia Allen and her colleagues, and therapists like Delon Pollard, who have passionately dedicated their life to the benefit, helping people with this model. So thank you for the opportunity, and thank you everyone for taking your time out of your busy day to listen.